Hello, everyone. This is Braswell Dean from the Providence Department of Family Medicine. We are back for our last section. It's part 6 of Codeology, and we have been looking at risk, data, and diagnostic management decisions as they apply to generating the complexity of medical decision making, which again is our ethical yardstick in how to assess the level of service that we provide for our patients so that we can code for our services ethically and appropriately in compliance with all the rules of coding. So let's jump in. I wanted to talk about a few more additional cases today. So we've already talked about risk, data, and diagnostic management decisions. If you haven't seen those sections or you have any questions, go back and look at them. If you want a little bit more practice, you can look at the section that we did in part 5, which put all of this together. But now this is kind of a bonus section designed to help you with your confidence. So let's look at cases for 10. Now, before we look at this, let me just stop here for just a minute. This is a patient that's coming in and wants to really spend the visit talking with you. And you think, can you bill based on your time? And let's look back at the worksheet. This is the worksheet that we've been using throughout the whole course. You should hopefully have it in front of you right now. It makes things really easy to look at. Up until now, we've looked at the risk section, the data, and the diagnostic management decision sections, and how easy these are to quickly calculate and to generate the complexity of medical decision making, and let that be the ethical way that you decide whether it's a new patient or established patient, what the code is for the visit, the service that you provide in that patient visit that day. And also we've talked about how this tells you the level of documentation that is required to support that code for that level of service. And then we've talked about how this documentation requirement tells you in terms of the history documentation and the physical exam documentation, what documentation is required. Because it doesn't matter if you generate the right code, and you don't document it properly, you still are not in compliance. So we've talked about all that, and you may say, well, that sounds pretty good, but I never do know what this section is down here at the very bottom is. And just know that this section is coding by your time. And I've put it down there at the bottom left, kind of off away from everything, to have it there for you so that you know you can code by time. And we're going to talk about how to do that. So you'll notice that the typical time is set up around whether you're a new patient or an established patient, just like we did up top with the MDM. And then I've got it subdivided based on the time that you spent. Whether a new patient is you spend 10 minutes, 20 minutes, 30 minutes, 45 minutes, or 60 minutes with the new patient. It tells you the code for the new patient, whether a 99201, 202, 203, 204, or 205, or whether or not you're looking at an established patient and you spend 5, 10, 15, 25, or 40 minutes with them, and that would correspond to the 99211, 212, 213, 214, 215 codes. So that seems like a pretty easy setup. And the minimum requirements in your note, I've put at the bottom: time in, time out, total time spent, and greater than 50% of the time was spent in consultation. That's the minimum that's required. So I've given you the codes based on whether they're a new or an established patient, and I've given you the minimum documentation requirements, just like we did in the other section. So with that being said, let's go back and look at cases for 10. So the patient comes in and, We've all been there. Patient just got out of the hospital and has a bunch of questions about the hospitalization because nobody really explained it that well, or maybe they did and I forgot. Or maybe their husband's in there with them now, their wife's in there with them, or their son or daughter's in there with them, the elderly patient. They want to ask more questions, or everybody's got stuff. Or maybe somebody's getting ready to have surgery and they want to ask you a whole bunch of questions like, do I really need this? The other fella said I needed it, but I don't know. Or you know what? I'm thinking about having surgery and I haven't brought it up to anybody yet. I wanted to see what you think of it first. Or you know what? I read something in the newspaper about whether or not this test is necessary or not, and I really want to do it, but I want to talk to you about it. Here's a few articles that I brought in. Let's talk about them. Like, whoa, what do you do with that? We've talked about risk and data and diagnostic management decisions, but that doesn't seem to apply here. Can I bill by my time? And the answer, of course, is yes, you can. But before I get into it, let me say something else. Because some doctors may say, you know what, this is a pretty good setup. I can just bill based on my time. I can code based on my time and not have to worry about the rules of coding. Can you do that? And the answer is you could probably do it, but it doesn't seem like as an ethical way to run your practice. Why? Because, and I've talked to many of the coders about this, these rules of E&M coding are set up to reflect your practice. And if your practice is that of a therapist, well, that may reflect your time. But if your practice is that of an internist or a family doc, a primary care doc, and or maybe a consultant, it's more or less assumed that you're going to be asking a chief complaint, history of present illness, review of systems, review of past medical surgical history, medicines, allergies, family and social history. It's going to be assumed that you're going to do a physical exam on these patients. So this whole course, as I've said before, has been built. We've tried to build this from the ground up based on applying ethical principles into every decision that we are instructing you about. And obviously, you can go, if you're at a practice somewhere, you can always ask the coders at your local facility. But the way rules are applied, we're teaching always try to base it on the most ethical way to apply these rules. And our coders at our institution say, if you bill everything based on time, you're probably going to get reviewed, and then people are going to say, this doctor is not doing anything but coding on time, and that's not the intent of all these E&M rules. What it does give you, though, is the ability for the occasional need to bill based on time, to code your services based on your time, because patients sometimes need to talk it out or talk about things. And so, yes, absolutely, it is ethical to code for your services based on time. But the expectation at the same time is that your practice in general is going to be based on services rendered based on history and physical examination of your patients. So I hope that clarifies those potential questions that you may be having right now. So how do you code based on your time? Well, for the typical time, as I said before, we've stratified this as new patients and established patients. And based on this patient, we spent 30 minutes in the room, time in, time out. Total time spent in counseling perhaps was 30 minutes or more, minimum of 25 minutes. Maybe I spent 25 minutes counseling. Maybe I spent more. Maybe I spent 35 minutes counseling. Well, I can only code for the amount of time I do. If it's 26 minutes, you still have to defer back to this. So this would be a 99214, and this corresponds to the 214 that we were talking about earlier, but we don't need this detailed documentation. The only documentation that we need is time in, time out, total time spent in counseling was X amount of time, and greater than 50% was spent in counseling. Time in, time out, total time spent, and greater than 50% of time spent in counseling. That's the minimum. You don't need this detailed documentation. But remember, the coders will tell you it is good practice to document as much of this conversation as you can, or the general topics, the important aspects of it, or if you examine the patient, somewhere in here too, the relevant aspects of the exam. But if you're billing based on the time, if you're coding based on your time, nobody's counting your bullets at this point. So you code based on the time spent, but not exceeding the time spent. So that's how you do that. Okay, so let's look at cases for 20. A 77-year-old male comes in with confusion. Your neuro exam is abnormal. The patient has obvious altered mental status, and you decide to send him to the emergency department for further evaluation and treatment. What is the level of medical decision making? And let's look at this for just a minute. Whenever you have mental status changes, I put this in here because this is another one of the AMA's examples. And we've made the point before that you can look at all of these examples and try to parse them out. It's not really helpful to try to memorize these conditions. These conditions don't fit nice and neatly into all these little categories. But this is one. Mental status is one you can usually, ethically, always hang your hat on. Your neuro exam is abnormal. Mental status, go into the emergency department. Risk, high. We just showed you on the worksheet. It's high risk. Mental status changes. You didn't order anything because you're not going to need to. They're going to need to be further worked up. New problem, needs workup. That gets you 4 there. They need a workup, and they're going to have it in the emergency room. So that's part of the plan. This is high risk, high complexity of medical decision making. So this is an example of using a 99215. And this is an example of a comprehensive exam being needed, okay? And other examples would be MI, PE, TIA, seizure, renal failure, making the new sensory loss, drug toxicity, making the decision for DNR. If you're rounding in the hospital and you make that decision, it's 4 points for your rounding that day. Or any acute or chronic illness threatening to life or bodily function. Now, we've said before that MI, PE, TIA, seizure, renal failure doesn't automatically mean that this is high risk. It has to be sort of documented in your chart that this is a threatening condition. Because once they get to the emergency department, when the emergency department sees the patient and has to obey these rules of coding, everything might be stable. So this is an example of using the 215. Now, let's take a quick look. New mental status changes, that's how we get our high risk. New problem is going to need a workup, 4 points. There you go. High, 99215, comprehensive exam. So there's an example of the comprehensive exam. And so remember, we got 7 just doing head, eyes, ears, nose, and throat, neck, respirations, heart, lungs, abdomen, all that, easy. So we really only need, from going to 7 organ systems to 9 is not a big leap. Maybe a neuro and a psych exam gets you there. Skin, inspection, no lesions, warm, moist, elastic. So this would be an example of using the comprehensive exam. I just wanted to let you see that this new problem like this, especially with any kind of a threatening condition, will get you the 215. Let's do cases for 30. A 22-year-old female comes in with vaginal discharge. She's a new patient, and she's worried about STD risk. So the patient has no past medical history, on no medications. The patient is examined, and cultures are submitted, and you do a wet prep in the office, and the wet prep in the office shows pseudohyphae. She is a new patient, as we said before, and you treat with some oral medication for vaginal candidiasis. Okay, what's our MDM now? Let's take a look. The risk is moderate. Why? Because we're prescribing medication for the candidiasis. We get 3 points in the data section. Why? Because we are, number 1, submitting a bunch of labs, vaginal cultures, HIV and VDRL tests. So it doesn't matter how many we order, we just still get 1 point. But because we view the wet prep, we get 2 points. For now, we get 3 points for the data section. This is a new problem needing a workup is 4 points. So we get 4 points here, but we have 2 levels in common here. So this one doesn't carry enough weight yet to generate this. So these 2 levels here make this a moderate, and this is a 214. Now, if she's a new patient, she would be a 204. If she is an established patient, she's a 214. And I think in this example, I think I circled 214, but I really meant to circle 204. So pardon me for that. But I've got it right here. And again, it does make the distinction that if it is a 204, we're going to be using a comprehensive exam. If it is a 214, we would be needing a detailed exam. And just remember that if it's an established patient, only 2 of the 3 sections are really truly needed. Complexity of medical decision and history. The exam part, even if you don't get to do all of the exam, it's technically not needed, but we are always trying to teach to try to do all of the 3 components of the code: complexity of medical decision making, history, and physical. So if we were doing the physical, a detailed physical we would try for that. Cases for 40. A 50-year-old is coming in with a complaint or desiring an evaluation of chronic hypertension, back pain, and a minor problem of allergic rhinitis. So they have a past medical history of hypertension, chronic back pain, and allergic rhinitis. The medications include a beta blocker and aspirin. The exam shows a blood pressure of 120/82. A physical exam is normal. You're managing all these chronic problems. All the chronic problems are stable. What is your level of medical decision making for this patient? Let's see how this codes out. The patient is on prescription medication, and the patient has 2 or more stable chronic illnesses. Easy, automatic, moderate level risk. We don't order anything, again, so our Data section is 0. Now for the diagnostic management section, we've got 2 stable established problems. We've got this hypertension and this chronic back pain, which seem to be holding their own today. They're doing okay. We get 2 problems for that. And this allergic rhinitis, minor problem, we'll give ourselves a point for that. We got 3. So moderate plus a level 3 here. Again, we get a 99214 for a established patient. Now, this always generates a question. Somebody out there is going to say, well, allergic rhinitis, well, maybe it's not a minor problem. It could be, and it's true. If you're an ear, nose, and throat specialist, allergic rhinitis is not a minor problem. It's a regular problem. Or maybe if the person's allergic rhinitis is a problem that they deal with every year, and every year you've got to prescribe something for them, well, then you just call it a regular problem. You can call it a minor problem if you want. You can call it a regular problem if you want, if it's a chronic condition. So again, this is up to your documentation. All right. Our last case, cases for 50. A 25-year-old comes in with a sprained ankle. Past medical history, none. Medicines, none. Exam shows a tender anterior talofibular ligament. Your assessment is mild ankle sprain. So you decide to treat with RICE therapy and a pneumatic compression splint and over-the-counter nonsteroidal medication. What is your level of medical decision-making for this patient? Let's take a look. Sorry, I didn't realize my margin was not right. So sorry about that. Those of us who are type A will cringe. Those of us who are not type A people feel no stress whatsoever. So the risk, as I've said, is low. Why? Because we're not on prescription medication. It's an acute, uncomplicated illness. So let's look at our form for just a minute. An acute, uncomplicated illness, simple sprain, an ankle sprain is one of those, allergic rhinitis, urinary tract infection. Now, if you're an ear, nose, and throat, and the patient has more significant, then it would be a chronic problem. But these are just examples that the AMA gives. And so to try to help us understand a little bit more, as we've said before when we were talking about risk before, sometimes we can depend on the way we use the medicines or the way we use our treatment to help us figure out the right level of risk rather than trying to put different diseases in these particular categories. Because we looked at the bug bite can be anywhere from minimal to high risk and all the way from high risk back down to minimal risk. We showed you that example. So, and if you hadn't seen that, you can go back and look at that part of that we dealt with risk. But again, with this one, we've got an ankle sprain, and I don't have to look around too much for this. I can just know that I'm treating it with over-the-counter medication. Now, this brings up a question. It always brings up a question, and I'm going to ask the question on your behalf because I know you can't answer right now, but what's the difference in a doctor prescribing prescription medicines for this sprained ankle and the doctors who's prescribing over-the-counter medicines? And I will tell you, this is one of these little areas that always generates a little bit of concern or questions. And I think ethically, you could say, oh, this doctor is prescribing prescription medicines when he could advise over-the-counter medicines. And is this doctor doing this so that he'll automatically get a moderate level risk rather than a low level risk for using over-the-counters? And, it's one of those things where, again, all the way through this course, we've tried to emphasize the ethical way to answer these little dilemma questions. And so once again, here's the ethical application, I think. I think you should always, whether you're looking at the rules of coding or not, you would always offer the simplest treatment for a problem before going to the most expensive treatment or the most complicated treatment. And obviously over-the-counter medicines are simpler. They're lower dosed. And again, the right dose of a nonsteroidal is the lowest dose that does the job, right? You'll see that on every bottle. So if we get in the habit of saying over-the-counter medicines first, then we're never going to be really accused to say, oh, you're trying to upcode through prescription medication prescriptions. Now, let's say you offer the over-the-counter medicines to the patient and they say, no, I want a prescription because I'm here. And then you'll say, well, what about over-the-counter? And they'll just look at you and say, well, you know what? It didn't work. It didn't work for me. So if that's the position you're in, I think it's at that point ethical to write in your note, over-the-counter medications, non-helpful, or no response to over-the-counter medicine. And that justifies the use of the prescription version of the nonsteroidal. And then, sometimes patients will come in with a sore throat and you're saying, you know what, I think you could just use a saltwater gargle. And the patient's saying, no, I want an antibiotic. And you'll say, well, no, your rapid strep is negative. Well, no, I don't care. I still want an antibiotic. And you'll say, okay, look, one fallback position I've always tried to stick with is say, look, okay, here's a prescription, but I'm not asking you to fill it right now. If the conservative measures don't work, then you can fill it later. Now, technically, for that visit, I haven't prescribed anything, and I wouldn't artificially be, just using a prescription medicine if it's documented in the note. Now, if it's in the EMR, it looks like I prescribed it because the EMR shows that, I printed off that prescription. But if it's in my notes, I wouldn't be, accounting that prescription medication right then and there. Now, of course, another way for that scenario is just say, no, I'm not going to prescribe any antibiotics, and you can call me in a few days. If you're not better, I'll send in the prescription. You can do it that way too. But I think back to this example is I always try and I always answer this kind of question to say, try to document in your note if your patient's declining the use of over-the-counter medicines, or they are asking for prescription medication because over-the-counter medications have not been helpful. So that's the way I kind of look at that question. So here we are back with a 25-year-old who comes in with a sprained ankle. You're going to use RICE therapy, a compression splint, and over-the-counter nonsteroidal medication. So what's your level of MDM here? So now with this, we have an example of low risk. Why? Because we are using over-the-counter medication. The data is 0. We didn't order anything. The diagnostic management decision-making is 3 points. Why? Because it's a new problem, but no workup is needed. I don't need to do an x-ray on the ankle. He can put weight on it. I don't need to, x-ray it. Okay, so in this scenario, I'm looking for the 2 highest levels in common. Well, nothing here in this section, nothing here in the moderate section, because there's no other, there's nothing else that pairs up with this level. So this level down here, this low level, has 2 things in common. It has the diagnostic management, which more than covers this level, and the risk. So now this becomes low. This becomes a 99213 expanded problem focus visit. Now let's look at this. So a 99213 right here, expanded problem focus. So in the history, we only need 1 to 3. Location, quality, severity of the sprained ankle. I could talk about duration, timing, context, or associated signs and symptoms and modifying factors if I want to, but it's not going to change the code. I can ask all these questions. Review of systems for expanded problem focus is greater than or equal to 1. I just have to ask one thing. You know, I could talk about the musculoskeletal system. It hurts. Well, what about anything else? You know, no chest pain, shortness of breath, or abdominal pain, or anything else like that. I can do all of that. But I only need one of them. So I can ask all these questions I want to if I want to, but it's not going to change the level that the ethical decision making for this visit is a 213. Past medical family social history. Technically, in this note, I don't need to document any of these. However, my trusty EMR documents all of these every single visit, every single time. It doesn't really matter. I don't need it for the note, but I'm reviewing it. And I can review it with a good conscience because it doesn't change the medical decision making. I'm not relying on the bullets from the history to generate this. For the physical expanded problem focus, look at this. It only requires one organ system, greater than or equal to one organ system, 6 to 11 bullets. So in other words, I could just examine the ankle, and I could just let all my bullets come from that. Or one organ system, I could examine the ankle and the knee. But what if I, as a doctor, wanted to look at the vital signs or look at the general appearance? Uh-oh, now I have 2 organ systems. Oh no. What if I wanted to look at their eyes or listen to their chest, you know, their lungs, or listen to their heart? Have I just committed some wrong thing? You know, unethical? No. I can do all of this if I want, or whatever I think is appropriate. Why? Because it's not generating the code. I'm no longer trying to let the EMR or whatever other system I'm trying to do count bullets and spit out the code. I'm not letting the EMR count bullets in the history and spit out the code. I have learned how to calculate the complexity of medical decision making. Probably one of the easiest things in medicine I'll ever learn are these simple rules that we have gone over in this little review course, in these 6 little learning modules. And whether you're a primary doctor or a consultant doctor, it's been said before that E&M coding is E&M coding is E&M coding. In other words, unless somebody radically changes things, these rules of E&M coding can apply whether you're in primary care or consultant care, or you're in the office, or you're in the hospital. E&M coding is E&M coding is E&M coding. And so this little review has been put together to try to help you learn to understand complexity of medical decision making and the fact that it is made up of the risk, the data, the diagnostic management decisions, and the ethical foundation that it can give your practice so that you can use this really quickly to calculate your the level of service that you provide your patients, and know that you do it in a compliant way, compliant with the rules established by Medicare services, and you can always be assured that you're appropriate for the services you provide your patients. So with that being said, I hope this little review was helpful, and we'll stop here and encourage all of you to, I hope you enjoyed it, and feel free to use it as you need to. Take care now.